Welcome to the WMed Specialty Spotlight Podcast, your virtual mentor for choosing a medical specialty and planning a career in medicine. On this podcast, we probe practicing physicians with questions about their specialty, the decision algorithm that helped them determine that the specialty was right for them, and then for advice about long-term career planning, irrespective of the field they went into. I'm your host, Dr. Biren Shah, WMed Assistant Dean for Career Development, learning with you all about the various medical specialties. Just a quick reminder that the show notes for this episode and all episodes can be found on our website at wmed.edu/specialty spotlight. If you would like to help support this podcast by sponsoring an episode or a physician willing to volunteer for an interview to talk about your specialty, please email me at bren.shaw@wmed.edu. The specialty of today's show is plastic and reconstructive surgery, and the physician here to tell us about it is Dr. Jesse Chou. Dr. Jesse Chou is a fourth-year resident physician in Plastic and Reconstructive Surgery residency program at the University of Virginia and is a clinical instructor in the Department of Surgical Services at WMed. He received his undergraduate degree at Amherst College and completed his medical degree with WMed in 2021. In addition to teaching, his academic interests lie in health services research and improving surgical outcomes. So without further ado, Dr. Jesse Chou. Dr. Chou, welcome to the show.
Perfect. Yeah, thank you, Dr. Shah, and thank you for having me on the program. Congratulations on building such a successful program that I think highlights a lot of the amazing faculty at WMed, and I'm sure is a tremendous resource for a lot of medical students as well.
Well, thank you. Well, it's great to have you here. So you heard me read your bio. Is there anything that you would like to add? And then maybe you can take us back to the time before medical school and walk us through the decision to go to medical school in the first place.
No, that's perfect. I think you captured my experience well. I look back fondly on my time at WMed and really have a lot of mentors there still that helped me get to where I am today. In terms of before medical school, I think I've always kind of knew I wanted to be in the medical field. I come from a family of restaurant owners and service workers that have always kind of prioritized service and really helping people in a tangible way. I knew with a background in science and humanities that medicine was kind of the perfect way to meld all those things in terms of science, humanities, service to others. Going into medical school, I knew I was pretty open-minded, but a lot of my early mentors were surgical, and I kind of found that the OR was the place I wanted to be in terms of how to best help patients.
Great. Well, I want to transition to the first part of the interview where I basically ask you to tell us everything about plastic surgery. And the way I like to start off the interview is by reading you a description of your field from the Careers in Medicine website, which is hosted by the Association of American Medical Colleges. And then I'll ask you what you think. So here it goes. Plastic surgery. A plastic surgeon deals with repair, reconstruction, or replacement of physical defects of form or function involving the skin, musculoskeletal system, craniomaxillofacial structures, hand, extremities, breast, and trunk, and external genitalia or cosmetic enhancement of these areas of the body. Cosmetic surgery is an essential component of plastic surgery. The plastic surgeon uses cosmetic surgical principles to both improve overall appearances and to optimize the outcome of reconstructive procedures as well. Special knowledge and skill in the design and surgery of grafts, flaps, and free tissue transfer and replantation is necessary. Competence in the management of complex wounds, the use of implantable materials, and in tumor surgery is required. Plastic surgeons have been prominent in the development of innovative techniques such as microvascular and craniomaxillofacial surgery, liposuction, and tissue transfer. Anatomy, physiology, pathology, and other basic sciences are fundamental to the specialty. Competency in plastic surgery implies an amalgam of basic medical and surgical knowledge, operative judgment, technical expertise, ethical behavior, and interpersonal skills to achieve problem resolution and patient satisfaction. Plastic surgeons also need to hone their ability to think in three dimensions as well as have good aesthetic sense, creativity, and appreciation for detail. Subspecialty certifications include craniofacial surgery and surgery of the hand. So how much of that do you agree with? What would you add or subtract to ensure that anyone listening was well informed of the practice of plastic surgery?
Yeah, thanks for kind of sharing that. I think that is actually a pretty broad and comprehensive definition of the specialty. I would say plastic surgery is unique in its ability to defy labels in some ways. It's a field that's as broad as it is deep. We don't really have an organ system to call our own. Some might say the skin, but we operate on all different types of tissues, which is one thing that attracted me to the specialty. So, skin, but also muscle, bone, nerve, blood vessels, the soft tissue, if you will, and even organs in some situations. One thing that kind of was mentioned in the description is transplant. And, a lot of people might not know that the first kidney transplant was done by a plastic surgeon. And the field has really evolved and transformed in many ways, kind of as time has gone by. But in some ways, the field is more defined by a specialized set of techniques. You mentioned free tissue transfer, or even just local or other, regional tissue transfer, or robbing Peter to pay Paul, as we colloquially say. And, at our most noble, we're restoring what, trauma or cancer has taken away, making patients whole again. At a health systems level, I think plastic surgeons are positioned well to bring a lot of value because we fit in so many different areas and ways to help other surgeons and help patients in a lot of different unique ways. I guess one thing that I would hone in a little bit on in that description is kind of the use of cosmetic surgery. I think that gets a lot of attention in plastic surgery. Somewhat of a buzzword, certain connotations, and it's kind of the largest public-facing aspect of our specialty, dealing, with aesthetic surgeries of the face, the breast, or the body. Not to get too much into it, but there's sort of, I don't want to say maybe a turf war is how to best describe it, but a lot of other specialties kind of start doing what they call cosmetic surgeries. And then there's this aspect of, is it a board certified plastic surgeon doing what you might call cosmetic surgeries? I think in terms of our field, we tend to call things more aesthetic surgery to kind of differentiate, who's an aesthetic plastic surgeon versus, a cosmetic type of surgeon that might have done a weekend course in liposuction that's going to be doing your procedure. And that's actually one of the big challenges facing our field in some ways. You can't really regulate those sorts of things, but in terms of patient education and making sure patients are getting the safest procedures done, that's probably one of the things that is a little bit of a hot topic. And the ANC website, I think the description otherwise is very comprehensive and captures a lot of our specialty, but the use of cosmetic surgery can bring up a lot of other kind of conversation topics too.
And thank you for that. You bring up, some challenges and, in terms of turf wars, in your opinion, what do you think the specialty will go in about maybe 10, 20 years from now? Do you see the specialty still being vibrant or do you see some issues where certain aspects of plastic surgery are going to other specialties?
Yeah, I think that's kind of the big, it's almost inherent to our specialty that we're constantly coming up with new techniques, but because we don't necessarily own an organ system, each organ system has another specialty that we share procedures with, or that we might even trade call with. For example, at University of Virginia, where I'm currently at, we alternate hand call with the orthopedic surgery service, and we alternate face call with the ENT or otolaryngology service. And that can lead to a lot of fruitful collaboration in many ways, but also some areas where some procedures tend to institutionally go to certain specialties a little bit more than others. For example, we share hand call with orthopedic surgery. So that means that half of the hand trauma cases that come in go to our department versus the orthopedic department. Half of the face trauma cases also get separated the same way. But then one area, for example, that has maybe gone towards ENT a little bit more is head and neck cancer reconstruction. You'll see that done at a lot of big cancer centers by plastic surgeons, but a lot of institutions that often goes to the ENT surgeons just because of the way the referral patterns work and things like that. But microvascular reconstruction using free flaps to reconstruct the head and neck is something that in many ways was pioneered by plastic surgeons, but is done institutionally by a lot of ENT surgeons today.
Yeah, I know as a breast radiologist working with the breast surgeons, I know at least at our institution, it's been pretty good in terms of collaboration with the breast surgeon, and then the plastic surgeon is also, doing their thing after the breast surgeon completes their task at hand. So, well, wonderful. Can you take me to, as far as what a typical, and I know you're still a resident, but kind of what a typical daily, weekly routine, a typical patient, and maybe it's not so typical because situations could be very different in terms, and maybe a typical outcome for this patient's look like. And you can adjust it to however you like.
Yeah, of course. So, it obviously will vary by provider and things of that sort. But in general, I would say most plastic surgeons have 1 to 2 days of clinic, and that's seeing new patients preoperatively, seeing consults, and then seeing their postoperative patients. And the OR is usually, or the operating room is usually 2 to 3 days. And, a lot of the listeners maybe listening to this, looking to pursue surgical training, might want to be in the OR 5 days a week. But something that, was a little bit lost on me as a medical student was that a lot of the thinking and the planning for surgeries, especially in plastic surgery, actually happens outside the OR. So whether it's an aesthetic or a reconstructive patient, shared decision making and kind of teasing out a patient's goals help to guide the surgery. There's not really a typical patient, but I'd say a typical outcome is hopefully restoration of form and function with an aesthetic result that's acceptable to both the patient and the surgeon. And I would say, every reconstruction or aesthetic surgery has a different goal, you could say, but there's a certain tension almost between what the surgeon might want to do and what they think is best and what might be best for the patient or even what the patient wants. So balancing all of those things and handling those nuances is a big part of kind of a typical outcome for a patient, or at least what you might call a best outcome.
Okay. And what would you say is really the most exciting thing about the specialty? And conversely, what do you find to be mundane about your specialty?
Yeah. I would say one thing that's pretty exciting to me, at least, is that every problem and every patient has a uniquely different reconstructive or aesthetic need. Because even if you're doing a rhinoplasty and all the nuance that's involved with that, or you're doing a free flat breast reconstruction, every patient's going to have a different sense of aesthetics, and you're going to have your own tools that you're able to do, and how those meld together is going to create a uniquely different problem for every situation. There is one concept of the reconstructive ladder, and that's essentially a stepwise approach in terms of the simplest to the most complex form of reconstruction. So in medicine, there's the concept of the right treatment for the right patient. In our field, we talk about the right reconstruction for the right patient. So for example, I might come up with a fancy free flap that requires staging and exhaustive postoperative rehab, but that might not be the right thing for that patient and their goals. Another thing that I find exciting about our field is how it's constantly changing. We're alluding to this a little bit earlier, but even within the last, I'd say 5 or 10 years, new areas, even within plastic surgery, are gender affirmation surgery, lymphedema surgery, and peripheral nerve. So just as a brief intro to those topics, gender affirmation surgery is kind of a new frontier. There's cutting edge techniques to help transgender individuals align their physical appearance, from the facial aspects to trunk and torso to even genitalia aligning those physical appearances with their gender identity, enhancing their quality of life. Lymphedema surgery is another emerging part of plastic surgery where you can utilize microsurgical techniques to alleviate chronic swelling after cancer surgery or other traumas and things like that to restore function and ideally improve quality of life for patients with this swelling from lymphedema. And then the last area that excites me, at least, about the field and where it's going is peripheral nerve surgery. And that's using, again, microsurgical techniques to repair and regenerate or facilitate regeneration of damaged nerves and kind of muscle motor activity. And that's another kind of growing field where we can use our unique, again, set of skills and tools to operate all over the body to improve form and function for patients. And I'd also include in peripheral nerve kind of migraine surgery, which is a little bit newer as well. But patients with, obviously migraines, multifactorial, multiple different etiologies, but for certain patients that have almost like compressive etiology to their pain, releasing those in a similar fashion that the carpal tunnel is released in the hand, that type of surgery can be beneficial to patients with migraines as well. So a lot of exciting areas and developments in our field. And I guess to add something mundane to round out the question. So a lot of plastic surgery is wound care as well. That can be an interesting part of our care, but I would say if you had to pick something to be quote unquote mundane, wound care, routine tasks like dressing changes, cleaning, monitoring wounds, and seeing them over time. I tend to tell people, or patients at least, that wound care is kind of like gardening. You don't usually make a lot of big changes fast. It's usually the small changes, de-weeding, planting the right soil, small changes every day kind of push the garden in the right direction. And unlike a garden, there won't be anything blooming, but you kind of make small changes and ideally steer in the right direction. And then sometimes you can, going back to the concept of the reconstructive ladder, a wound can heal by secondary intention or, very minimal intervention, or you might need to do a skin graft, or you may need to move tissue around to cover it, or in the most complex situations, put a free flap on that wound. But I would say just the general wound care and that kind of tedious, maybe daily task of tending to a wound can be mundane to many.
Thank you for that. Nice analogy in terms of with gardening. What is one thing you would have wished that you would have known before entering the specialty? And what would you encourage a medical student to think about in earnest before committing to go into your specialty?
Yeah, great question. And I had a sense of kind of exploring plastic surgery a little bit more, but I would say to the plastic surgery interested medical student who's interested, a lot of what you see on TV is kind of what we were talking about earlier with the aesthetic procedures and the cosmetic plastic surgeon. But as alluded to in the AMC description, it's a broad field that encompasses, reconstructive plastic surgery, hand, craniofacial, and each of those, as you mentioned, can also be an opportunity to do a fellowship and get even more subspecialty training. So, to put it bluntly, I just want to advise medical students to, make sure they know what they're getting themselves into. You might think that you're going to be doing facelifts and, blephs only, but you might find yourself in the middle of the night reducing a distal radius fracture or repairing a facial nerve injury, trying to reattach a thumb, and doing kind of all the other parts of plastic surgery as well. But personally, I love that our field encompasses the entire human body anatomically. I think for those surgically minded, you kind of look at what procedures you'll be doing, what anatomy you'll be interfacing with. And I love that you'd be operating head to toe in plastic surgery. But again, that brings up what we were talking about a little bit earlier too, with in terms of the potential turf war with different surgeons and other specialties that might feel like they own a certain body part or a certain anatomic region. But more often than not, again, like we share those procedures that can vary institution to institution. And a lot of times it ends up working out. There's plenty to go around, so to speak. I would say by nature, we end up just collaborating with those specialties a lot. And I would say in terms of a medical student wanting to go into plastic surgery, another thing to really think about is what they really like about plastic surgery. So for me, I like the versatility and the breadth of the specialty and the opportunity to go in depth and be a subspecialist. But I would say, for example, if you were interested in being a hand surgeon, you can go through that by being a plastic surgeon or an orthopedic surgeon. And there's pros and cons. They're a little bit out of the scope of this podcast for either route. But for example, if you love the idea of being a hand surgeon and also wanted to be, an elbow or a shoulder surgeon as well, that might be something that you'd get more exposure to going the orthopedic route. So that might be something to think about a little bit more. And you could argue that soft tissue and nerves are something that you get more exposure to in the plastic surgery route. And then, going back to the example of a rhinoplasty or a nose job, as the public might know it, you could also kind of do that as either a plastic surgeon or an ENT surgeon. And, I would say, for example, to play devil's advocate, if you were interested in working in the sinuses as well and, kind of doing some of those types of surgeries, then, the ENT route might be more suitable for you as well. And another quick example would be breast surgery, as we talked about. So a general surgeon is typically who does the mastectomy and manages the oncologic care. But a plastic surgeon is who does the reconstruction and kind of brings the patient back to whole and helps guide them through that process. So you might say you love working with breast cancer patients, and then you could think about whether you want to be the person kind of guiding their oncologic care and removing the breast and being there at the very beginning, or if you want to be the surgeon who talks to them about, what's the best reconstruction, what are their goals, and guiding them through that process. There's different avenues to kind of get what you might want out of the patient experience and the relationship you have with patients and the role you have. So, a little tongue in cheek in some of those examples, but the point really to think about what they're uniquely attracted to in the field and how it can overlap with other specialties. And is there a better fit before you commit to, kind of in some ways a very specialized field?
Mm-hmm. Oh, yeah. Yeah. And how does the practice kind of change based on setting, like inpatient versus outpatient, academic? You're obviously at an academic center. Private versus public, urban versus rural?
Yeah, great question. And I would say in terms of mirroring other specialties too, the larger procedures tend to be done at the academic centers. For example, our biggest procedures, face transplants, hand transplants, or any really big, large reconstructive free flap, those tend to be in those academic centers where you have the needed infrastructure and specialized equipment. For example, we're doing lymphedema surgery at UVA, and we have a very specialized microscope that lets you suture on vessels that are 1 millimeter in diameter sometimes. So, so things like that, or all of our free flap patients tend to go to the ICU just for, post-operative flap monitoring. They tend to be not as sick as you might find in the ICU, but in terms of the monitoring and things like that. So I would say that tends to be more at those academic centers. And you can do free flaps and things like that in more, smaller practices, but it just tends to be maybe more elective and things like that. I would say another classic model, though, would be the aesthetic plastic surgeon who works in a solo practice or a group practice. And in some ways, they're running a small business. So there's kind of like a big bifurcation in terms of private practice and then academics. And then you can really kind of branch those out into, employed practice, private-demics, and there's, a lot of different practice models. I would say you just tend to maybe do fewer procedures, but you might be able to do them at higher volume, this kind of the smaller the health system you go. And then I would say international work tends to focus a little bit more on burns, hand, and, cleft lips classically, with a lot of big nonprofits that tend to do those types of procedures abroad. And obviously we do those domestically as well. But I would say, like, when you go international, and there's obviously some variability, but I would say from my experience, it tends to seem to be more burns, hand, and cleft lips type of thing.
Okay. No, thank you for that. I want to transition to the second part, and that is kind of tell us about how you decided your specialty was right for you. Can you tell me your struggles, your insights, and that eventual aha moment that made all sense that you wanted to go into plastic surgery?
Yeah, of course. Thank you for that question. When I started medical school, and you can ask, my classmates at WMed, but I really tried to keep as open of a mind as possible. I wanted to learn as much as I could from each rotation and really try to imagine myself in each of those specialties. That said, I eventually found that I did want to be in the OR. I felt like the place in the hospital where you could really acutely intervene and treat patients and see results in real time, work with your hands and affect that tangible change I was talking about earlier. That seemed to me you're in the OR, and that, as well as love for anatomy, a love for being in the OR. I think when you're in the OR, you kind of have a sense of whether that's the right place for you or not. But one thing that I saw when I was rotating on surgical service, and again, a lot of my mentors at WMed surgeons, and I respect them and look up to them, and a lot of them have been on this podcast as well. But yeah, I think one thing you see is the same operation over and over, and a lot of times that's by design. A cliche among surgeons is that they do it the same way every time. And I think there's pros and cons to that. But the more and more I saw, I think surgeons tend to get highly specialized, and they do the same handful of procedures with maybe minimal variation to each one. I was able to do an away rotation at the University of Michigan as a fourth-year student, and there I was able to see that reconstructive cases were a better fit for me. So I saw one case was using part of a kid's thigh to recreate their foot. I got to see the problem solving and the planning involved in that. Then recreating their foot, that patient was able to walk again after having a traumatic accident. Another case was using abdominal tissue to reconstruct a woman's breasts after having mastectomies for breast cancer. In another case, I got to see a cleft lip repair. And that, I really just kind of found that plastic surgery was everything I wanted in terms of, the variability in cases, the head to toe anatomy. And again, a specialty kind of as deep as it is wide. The field is evolving and it's changing. It looks different than maybe it did even 10 years ago, even 5 years ago when I kind of started getting interested in the field. But there's some timeless procedures like cleft lips that you kind of refine and you get better at over time. Then the areas that are evolving, like I mentioned earlier, gender, lymphedema, and peripheral nerve, just to name a few. But that was kind of how I thought through the process of picking a specialty and finding one that was right for me. And everything that I just described is perfect for someone like me who kind of is looking for the next big thing and wants to work all over the body. And in some ways, it's impatient because I want to see my results right away. And in some ways, can't focus because I want to be doing a lot of different things and have that range and versatility. And in some ways, that is well suited to my personality, but that might not be right for everyone listening or everyone kind of deciding what specialty is right for them.
Was there ever a head-to-head decision between two or more specialties? As you know, and I mean, the elephant in the room is, plastic and reconstructive surgery is a very difficult specialty to get into. Did you have a backup plan in terms of a parallel plan?
Yeah. Yeah, I like that kind of phrase. I think they used that when I was a medical student, but parallel plan, because and I hesitate to use the word backup when I say what I'm about to say, but and again, I wouldn't necessarily advocate for what I did, but I did apply to both general surgery and plastic surgery programs, and I even went on interviews on both. And I did that partly to maximize my chance of matching, but also to gain as much knowledge as I could. Just really keeping an open mind in each interview. I think a logical route even would have been to do general surgery and then plastic surgery, since it's a fellowship that you can do after general surgery. I'm happy to talk to anyone about that decision-making process as well. But in the end, I looked at all the possible career paths that you could have from either one. And I just realized that I would be more happy starting in plastic surgery and then choosing from there which of the subspecialties that I would potentially be interested in, rather than kind of starting in general surgery and then going into plastic surgery and then kind of doing it that way. But I do feel like I would have been able to find my place in general surgery as well, even if that would have meant plastic surgery. And again, I didn't really try to think of general surgery as a backup plan, because there are, academic general surgery programs are very, difficult to get into, of course. And all of my mentors essentially at WMed were general surgery trained, and I look up to them and respect them a lot. But it's a very individual process and decision. But ultimately, I found that I'd be happier with the kind of paths available to me in plastic surgery, and kind of for the reasons I mentioned before, why it'd be a better fit for me.
going back as far as you touched upon, two paths. One can go into directly into plastic surgery and
Yeah.
reconstructive residency program, or you can go into general surgery and then do a fellowship. Can you kind of talk between the two differences in terms of number of years, going the path of general surgery, then a fellowship, into plastic surgery? And is it any easier to get into a fellowship into plastic surgery?
Yeah, great question. It's fun. It's kind of funny when I remember going through this entire process as a medical student, and it's one of those things wherever there's two or multiple routes, people tend to think that whatever they did was kind of the best route. Yeah, so I would talk to attendings that did the independent route, which is what you call doing general surgery first for 5 or 7 years, and then doing plastic surgery as an integrated route, which is 6 years typically. And I found that whoever I talked to, the people who did the independent route said, yeah, the general surgery training really gave me a solid foundation and gave me the skills that I needed to become a sexual plastic surgeon. And I thought that that was the best route. And the independent route is 5 years of general surgery training. And there may be 1 or 2 years of research or academic time at a lot of these academic programs. And then when you apply for a plastic surgery residency, it's typically 3 years now. So that would be, you're looking at 8 to 10 years in terms of finishing and being eligible to be a board certified plastic surgeon. You are also potentially certified in general surgery as well. And I'm not going to speak to how useful that might be, but that's just something that would be possible if you were to go that route. And I would say, as someone who didn't apply that route, typically people say that's less competitive to do a plastic surgery fellowship after general surgery residency. That being said, you'll look at a lot of programs across the country transitioning from the independent route to the integrated route. For example, when I matched at UVA, there was one independent spot and one integrated spot every year. And now we've transitioned to 2 integrated spots per year. In other words, we don't have the option anymore for general surgery trained residents to apply and do fellowship with us. And you'll see that across the country. Every spot or every program kind of has this decision to make in terms of, do we like this model? Do we transition? And then, so the integrated model, just to speak a little bit about that, would be matching directly as a fourth-year medical student and doing 6 years of plastic surgery integrated training. And then at that point, being eligible to be a board certified plastic surgeon. So you're looking at 6 years of training versus potentially 10 years of training. And again, people who do either, they kind of say what they did was, because everyone only kind of trained once, so to speak. But for the integrated pathway, I would say traditionally that used to be even 3+3. So you would do 3 years of general surgery training dedicated in some ways, and then go 3 years of plastic surgery training. I would say at UVA, we're doing what a lot of institutions are doing, which is earlier exposure to plastic surgery. So when I was a plastic surgery intern, I did 4 months of plastic surgery, and that's on top of my general surgery rotations in orthopedic surgery, ENT, ophthalmology, dermatology. So you're getting exposure to plastic surgery earlier, and you're also doing general surgery rotations, and in some ways getting that experience that people say is beneficial from doing the other pathway. And I would say I've loved my training so far. I've thought it's all been useful and helpful. And just weighing in on both of them, I would say it's hard to argue with earlier exposure or earlier plastic surgery, or more plastic surgery earlier. Sorry. But I'd say there's pros and cons to both, and you'll get good training either way. And in every case is useful that you do. Even if you're doing Whipples as a general surgery resident, I'm sure there is a lot of translatable skills and things like that to what you'll be doing in plastic surgery.
Great, thank you for that. And as far as plastic surgery residency like that you're in, do you find individuals after they finish their plastic surgery residency decide to go into fellowship, or is something not typically done?
Yeah, great question. So I would say it's a mix, like a lot of things, but if you were to say after plastic surgery residency, I wanted to go into private practice and I want to do face, breast, body, body contouring, I would say that person's probably going to be pretty comfortable doing that. I would say if you want to go into private practice and you want to do breast reconstruction and do deep flaps, and you want to do implant-based breast reconstruction, body contouring, things like that, you'd probably be pretty comfortable doing those things as well. But if you want to get an academic job doing those things, or you want to subspecialize in craniofacial, hand, microsurgery, even aesthetics, you could really get a lot out of doing a year and honing your skills in those things. In fact, in hand, it's almost required nowadays to do a fellowship because of the CAQ certification that you would need to get. In some select cases, you can do an embedded fellowship within the residency because the residency is so long, 6 years. In some institutions, you can do a kind of embedded fellowship and get that eligibility and the experience to do that out of residency. But most of the times, hand surgeons are doing a hand fellowship, whether you're doing orthopedic surgery or plastic surgery. You're doing a year of dedicated hand and microsurgery upper extremity fellowship to be able to sit for the CAQ. For craniofacial, I would say if you're going to be practicing craniofacial surgery and you want to do craniosynostosis, you want to do cranial vault remodeling and these kind of big surgeries, you're going to want to be at a children's hospital and an academic center. And a lot of times you're going to be needing to do those fellowships to gain those skills. You'll get a lot of exposure to it in residency, but oftentimes to get those jobs, you'll have to kind of show that you did a year of that really in-depth subspecialized training. Microsurgery is kind of a funny one because I would say if you want to be an academic microsurgeon, my anecdotal observations are that you would also need that year of fellowship, but it's, it's very reasonable to do microsurgery without a microsurgery fellowship. In fact, many of my mentors and people of a certain generation get grandfathered into that, so to speak, and are able to do microsurgery. And because again, it's kind of a set of tools. There's no special certification or anything like that. But to get exposure to, for example, those highly specialized areas of microsurgery, so, VCA or vascularized composite allotransplantation, like hand transplant, face transplants, or lymphedema surgery, or even some peripheral nerve experience, a lot of that would be better suited to you to get that training in a fellowship. So all that to say is, you don't have to do a fellowship, but it depends on what you want to be doing in your career, what kind of procedures and what kind of practice setting you want to be in. Definitely not a necessity, though.
Great. Thank you for that. And my next question is I call the third year question. And if you were a third year medical student, undecided on the specialty with limited time remaining before residency applications were to be submitted, what do you think would be the fastest, highest yield route to making the decision about the specialty?
Yeah, I would say that person, you can defer the decision a little bit if you were to apply to multiple specialties like I did. But doing the way rotation, while not necessarily the fastest thing, is probably the most informative thing, just because you're able to kind of see what it's like at a different institution, gather more data points. It's almost like doing a research study. Having a multi-center, set of data points is a little bit more useful because in some ways you can only really picture yourself based on the mentors. You're limited by the mentors you have at your home institution, which, while amazing, are going to be naturally limited by the context they're in. But in terms of the fastest, highest yield, I would say picking and attending in each specialty and really looking at the kind of patients that they see, kind of procedures that they might do, their kind of experience and what their practice looks like, and seeing if you could imagine yourself doing that. And if that you could see yourself doing that, I think as a medical student, you're tempted to kind of look at the residents, but that's really, the grand scheme of things, a short time in terms of your career. And you really want to look at the attendings and kind of look at, like, is that the life that I can see myself doing? Is that what I want to be doing? Is that what I can picture myself doing? So that's probably what I would say in that situation.
Great. Thank you for that pearl of wisdom. For plastic surgery, are away electives necessary?
In short, yes. I would say, in typical years, an applicant does 2, 3, in rare cases, even 4 away rotations. I only did that one rotation that I mentioned at the University of Michigan, but I applied during a time of a global pandemic when that was limited. But I would say in general, 2 to 3 is pretty standard, and that's on top of a home rotation. Um, and honestly, there's a tremendous benefit to your application, but also just in terms of education and things you learn. When I was a medical student, people used to even say you should rotate on plastic surgery just to get exposure to working with soft tissues and suturing and things like that. So, there's tremendous educational value to doing them as well. But even just from an application perspective, I would say yes. If you're interested in plastic surgery, you should probably do away rotations. Although in some ways it's kind of funny because if you were to apply to multiple specialties, the general surgery program director might ask you, why are you applying to general surgery? You have 3 plastics away rotations. So there's a little bit of strategy and things like that. But in short, yes, you should be doing away rotations.
Great, thank you. And how important is research or scholarly productivity for matching into plastic surgery?
Yeah, it's incredibly important. In some ways, I've kind of gone back and forth on my thinking about this, but it seems like looking at students applying, especially being on this side of it now, and meeting students who are applying to plastic surgery and seeing what they're doing. There's almost kind of like an arms race now where they're doing a research year. The question used to be like, should I do a research year? And now it's almost like, how many research years should I be doing? I'll meet students that have done 1 to 2 research years. And I don't want to scare students listening, but it's becoming more and more common. We have 4 medical students doing research here with us at UVA this year, for example. And I didn't actually personally do a research year, but I guess I get asked all the time whether it's useful. And the reality is it's becoming more and more competitive. More and more people are doing it. But there's not really a change, I would say, in people going into academics after residency. So in some ways, people are playing the game and learning what to do to match. But again, that's another year that can be informative, both learning about yourself, learning about the specialty. But in terms of just pure application benefit, I would say, a lot of people are doing them these days, and it's a proxy for how important research is. But to be honest with you, there are some things that I'm personally interested in doing research in, but I've always kind of seen research as kind of a proxy. Like when you look at a medical student and their application, it's really hard to know because every letter will say that they're hardworking. Every letter will say that they can, they're high functioning, high degree of agency and can get things done. But when you look at someone's research productivity, whether they're interested in it or not, I think an interest helps you do it, but it almost acts as a proxy for, can this student complete a project? Can they see a project through from start to finish? Are they a finisher? And I acknowledge that research a lot of times is kind of just luck of the draw. Are you in a lab that's productive, et cetera? But in some ways, it's a proxy for how much grit a student can have and how hardworking they are and things like that. So it has a purpose, has a role, for better or for worse. It's an important part of the application.
You mentioned about taking a leave of absence. How often do you see that in applicants in terms of taking a leave of absence to do research? And if a student doesn't have much research and they're coming into, they're in their 3rd year, are they at a major disadvantage? And should they be contemplating about taking a leave of absence?
Yeah, great question. I think it's becoming more and more common in plastic surgery. But that said, I remember talking to a lot of my mentors, and the bar is it's interesting because it just really depends on the specialty. There's some specialties that don't necessarily hold research to such a high degree that these smaller subspecialty surgical specialties do. And then I would say in those situations, the typical formula works, like do well on your clerkships, get good letters of recommendation, do well on your boards. But I would say research is one of those things that has been amplified more recently as well. And I'm sure this is kind of a can of worms too, but I think in making step 1 pass fail, I think there's a lot of good intentions going into that in terms of leveling the playing field, making things more equitable. But in my mind, and kind of talking with others, it seems like you make step 1 pass fail, that just adds more weight and influence to the remaining parts of the application that are more variable. So for example, whereas like research was weighed, maybe moderately before, now with step 1 pass fail, removing that as a variable, and now it's more important because what else are programs using to evaluate applicants? And honestly, I don't know what programs are using as much nowadays to evaluate applicants. So I would say you're not in a terrible position if you're going into third year and you don't have any research, because I think that's the situation that a lot of people are in. But I would say if you are interested in plastic surgery, if it's not research, there has to be some way where you've shown an interest in the field, whether it's getting involved at the medical student level in societies or professional groups or things like that, or even doing the away rotation eventually. You have to demonstrate interest in the field, and I think that's something applicable to every specialty. They want to know, is this someone that's going to, help the field, push the field forward, and are they a good fit for even the residency? Have they thought about the field and how they're going to be a good fit for our program, but also this specialty? Are they someone that's going to maybe do a year of residency and then realize it's not the right fit and then have to change specialties? Or, those are all kind of proxies for the question that they want to know, which is this person going to be a good fill in the blank doctor? Is this person going to be like, you're trying to prove in some ways that you're dedicated to the field and that you're going to, make a contribution. So research is kind of like a proxy for that. A lot of people don't end up going to academic plastic surgery. If I had to kind of anecdotally make up numbers a little bit, I would say 2/3 of people go into private practice plastic surgery after residency, or probably even more. So a lot of people aren't going to be going into research. But then if you look at people doing research years, I would say definitely more than half for plastic surgery. So then you kind of wonder, like, where is the disconnect? And part of it's just kind of playing the game to match and making yourself the most competitive you can. So that's just the reality of kind of where we are today, I think.
Yeah. Yeah. And you touched upon this. Is there anything else a student should be doing to be a competitive applicant for plastic surgery?
Yeah, I think this is going to sound a little corny to me, but just being the best medical student you can. So learning as much as you can, doing the best you can on every single part of your application. I got asked when I was applying, you can imagine I applied to 2 specialties, so I went on a lot of interviews, and I just got asked about almost every single part of the application you could think of. Like, what about this clerkship grade? What about this letter? What about this activity? What about this research project? So in some ways, you just have to be well-rounded and strong and everything. Not that I was, the most well-rounded or strongest medical student, but really just kind of pursuing your curiosity and really setting yourself up for being a lifelong learner, to use another cliche. But you want to position yourself not only to be the best applicant, but to be the best doctor. So I've been, in plastic surgery, and there's been a lot of areas where I thought, I'm going to be a subspecialized plastic surgeon. I'm not going to need to know a lot of these things. So, for example, I was on OB-GYN when I was when COVID pulled medical students out of rotations, and I did OB-GYN online, and I remember thinking, oh, I probably won't need to know a lot of this type of anatomy. But now I find myself doing pelvic reconstructions with my attending. And working with that anatomy a lot, actually. Or I find myself helping with a gender affirmation surgery where I'm working with that anatomy a lot, actually. So you never know what's going to be useful to you as a doctor later. And, just learning as much as you can kind of set yourself up to be the best doctor you can later. It's tough being a medical student, though. You have to kind of do everything everywhere all at once.
Yeah. Yeah. Is there any resources, online resources or otherwise, you'd recommend to help a medical student learn more about the specialty of plastic surgery, as well as to help them get into plastic surgery?
Yeah, I would say talking to as many people as you can is going to be the most helpful. I'm happy to put myself out there as a resource for anyone interested in plastic surgery that's listening. But just hearing as many perspectives as you can, and I think hopefully taking all that volume of information in can help you kind of push a little nugget of clarity and decision making forward. It's always interesting to me. I think everyone comes at this from different angles, and it's such an individualized decision that only you can kind of make that decision for you. But you're the one that has to be that kind of doctor for however long of a career. So you have to be the one to make that decision. But I think talking to as many people as possible can help you kind of make that the most well-informed decision you can make. resources for plastic surgery kind of include, the ASPS or American Society of Plastic Surgeons website. That's kind of like our main society. I would say looking at that for in terms of the public facing website for our specialty. And then our kind of flagship journal is Plastic and Reconstructive Surgery, or PRS. I think looking at that journal to see what topics people are discussing and researching can be a useful resource as well. And then in terms of studying, I would say if you want to know kind of the content that you might be asked to know as a plastic surgeon, and definitely as a plastic surgery resident, the Essentials of Plastic Surgery book by Jeffrey Janis is kind of a classic one. And that kind of gives you a good overview of our specialty. Like we've talked about, it's cosmetic, aesthetic surgery, but it's also hand surgery. It's also craniofacial surgery. It's also, taking care of burns. It's wound healing. It's all these kinds of things that make our specialty so broad and so interesting. But yeah, I would say those are helpful things. And yeah, talking to as many people as you can is probably the biggest one.
Great, thank you for that. And we'll make sure that our listeners have that information that will be put into the show notes. I'd like to transition to our last part, and that is kind of giving advice for long-term career planning, irrespective of the choice of specialty. If you could go back and do it all again, what would you do differently, and what would you do the same, and why?
Yeah, thanks for that question. So it's hard to answer questions like that whenever I do get asked that, because I really am very satisfied with how things turned out, and I feel so lucky. And things just kind of turned out well, both personally and professionally. But I would say in terms of advice to give, when you're applying, I would apply widely. Especially if you're applying to a small specialty like plastic surgery. I targeted certain regions of the country as if I was a more competitive applicant than I actually probably was. And things work out, but I would say just apply widely, keep an open mind. I would not necessarily advocate this, but for example, I know people that applied to every single program in plastic surgery. And you could do that. I mean, financially, that's probably the biggest obstacle. My roommate at WMed, actually, he applied to every single program in urology. So, these small subspecialties, you can cast a wide net. And then it's hard for the programs, right? Because they have to then tease out who's genuinely interested in coming. But, that's one thing. I wouldn't apply to every program, but I would have applied more broadly is what I'm saying. And then I would say, another thing would be to enjoy the ride in terms of advice to give. You never know, again, kind of like what I was talking about earlier, but you never know what knowledge will be useful. You never know what you'll learn in different settings. You'll be surprised at how much of these other kind of disparate fields of medicine, obviously if you're applying to internal medicine, a lot more will be maybe more relevant to you as a medical student. But like even in a field, again, as subspecialized as plastic surgery, you never know what's going to come back from other fields that is going to be useful for you. Like I mentioned in terms of OB-GYN, and now that anatomy being relevant and useful for me in some ways. It's all connected and it's all useful. The biggest advice I would give is just to invest in yourself and do as much research as you can, both research in terms of the specialty, but also research that goes on your CV and helps you match. Putting yourself out there and asking about, is there any research project I can help with? You never know what's going to kind of lead to fruition. As a medical student, I remember my strategy was to always say yes to any research project, because a lot of the times things didn't pan out. So you never know what's really going to be a useful research project. And I didn't have this when I was a medical student, but now that I have real academic interest, I can come up with projects and I know the field. And it's a little bit easier as a resident or as an attending to do this. But I would say if you really want to be a go-getter, one way to get things moving is to, instead of going around saying like, is there anything I can help with? Is there any research I can help with? But saying like, oh, I was looking at a paper that looked at this. I think with our institution, we could look at our data this way. And I think there could be an interesting study where we look at blank. Coming up with a really cohesive, well thought out plan is more likely to get an attending's interest and support, and also more likely to get you somewhere in terms of research. And honestly, I think that's just a piece of advice for being a medical student, or being like a junior member of part of a team. So it's funny now, just as a brief aside, as a resident, I'll have a lot of medical students ask me, what can I help with? And that's great. That shows they're enthusiastic, they're open-minded, they're eager and willing to help. But actually, that it's funny because in some ways it gives me a task now because now I have to think about, okay, what is a task that they can help with that's level appropriate that I can make sure they can be held accountable for. More helpful, and there's a lot to ask maybe, but as a medical student that comes to me and says, hey, I noticed from rounds that this task has to be done. I've done this before. I noticed this drain has to be removed. I'm comfortable removing drains. Can I go remove that drain, for example? Then it's like, yeah, that'd be great. Thanks. Let me know when it's done. So, that kind of next higher level order of thinking in both, on the wards and also in research and things like that. I guess you could call it taking initiative. I think that's one thing that I would say is going to be useful for students going forward.
Great. What would you say is a career mistake that you've seen other physicians make?
Yeah, I think a big one for a lot of physicians and plastic surgeons too, of course, is neglecting work-life balance. So a lot of physicians, we become so engrossed in our professional responsibilities that you can overwork yourselves, and burnout is another one of those big cliche topics that you talk about in certain fields, decreased job satisfaction. But for example, one of our so being a reconstructive microsurgeon, a lot of times that means working with other surgeons and helping them with their complications a lot of times. So for example, or not complications, but even their surgeries and their big resection. So for example, spine surgeons, you have a lot of respect for what they do, and they have really long hours and big tasks, and they might start a case at 7:30 first start and go all day, all night, and they might need our help closing, mobilizing well-vascularized muscle flaps to cover their hardware that they spent all day putting in. And a lot of times that can be, late at night, 9 p.m. or later. So you can imagine it can be very easy for a reconstructive academic microsurgeon to spend long days, long nights at the hospital. And I've just seen that really take a toll on a lot of different surgeons in general, and unpredictable hours, long hours. These are the things that can be tough. But one of my attendings, I think, is really good about setting boundaries. So he might say, hey, I'm available up to this time. And that lets the ablative surgeon know, like, hey, like maybe I need to reschedule my surgery, or I need to do this on a different day. And, obviously emergencies are one thing and that's a different situation. But if you're planning a complex surgery with a surgeon, then, one thing they can do is to know, like, oh, okay, if X attending is not available after 5 p.m., then I'm going to not put my spine surgery as a third start. I'm going to maybe put it as a first start and try to, optimize the time where they'll be available and respect their boundaries and their time. And there's a lot of, things, and not to disparage any other specialties, but there's ways that they can set us up for success as well. But there's also ways in which we can set boundaries and really try to take a little bit more control of our time and set that work-life balance, and emphasizing the importance of that, I think, is just I'll leave listeners with.
No, thank you for that. What's one thing that maybe perhaps you're struggling with or lamenting about your career today, and what are you doing to remedy it, and what would you encourage a medical student to do right now to avoid this problem entirely later on?
Yeah, great question too. So I would say one thing, and this might be only me, the only person in the world that feels like this, but in a field where I have to do so many different things, it's easy for me to feel kind of average in a lot of different areas, a jack of all trades, kind of master of none type of idea, where, I'm doing hand surgery with the orthopedic surgeons, I'm doing face surgery with the ENT surgeon, and I want to be honest, better than them at each of those things. But it's difficult because you kind of have to be so good at so many different things. And I do find myself feeling like it's easy to be average. And I don't want to settle for that. But it's easy to kind of just like meet the bare minimum and get a patient an adequate reduction and then, call it a day. So that's something that I personally am struggling with. And the way I want to remedy that is to, be collaborative and learn. So for example, if I feel like I'm not doing as good of a job with a distal radius reduction, I'll talk to my orthopedic colleagues and I'll say, hey, like, what are you guys doing that's different? How do you set up the hand differently, or what can I learn from you? ENT is a little different because I don't feel like I can learn anything from them. But no, I'm just kidding. But really, I think having the collaborative mind and nurturing a curiosity is kind of how I would approach doing that, and setting yourself up to be, again, a lifelong learner, and really having a growth mindset is probably how I would advise people to do that. One thing that I would also emphasize to anyone listening, medical students especially, skills that I didn't really work on, I would say, as a medical student, or even as an even more junior resident, are things like managing patient expectations, being able to say no to surgery for a patient. Those are obviously more on the attending than you as a resident or a medical student, but those are things that are super important skills that I think are not emphasized as much, because without those abilities, you can end up with unhappy patients, or in the worst case scenario, a lawsuit. But they're skills that you actually learn in clinic and talking to patients preoperatively. And they're things that you don't learn necessarily in the OR, whereas like a lot of times the operative skills, technical skills are what are emphasized in surgical training, but there's important skills to be learned in clinic as well. And I think that sets you up to avoid a lot of headache and burnout down the road as well.
Great, great. Thank you for that. I like to ask at the end of an interview, what is one book, medical or non-medical, that you think every person pursuing a career in medicine should read?
Yeah, I've looked at some of the previous responses from authors, and a lot of great books have already been mentioned. So I'll echo, for example, When Breath Becomes Air, and all that works by other authors that have written on the medical field. So one of my mentors at WMed gave me the book Better by Atul Gawande. So he obviously has a lot of great works as well. So I'll echo all those. But in terms of giving a non-medical answer, one book that really helped me think about things is Adam Grant's book, Think Again, The Power of Knowing What You Don't Know. So this is like a nonfiction, highly evidence-based book where he explores the importance of rethinking and questioning your own beliefs and assumptions. It focuses on the value of, I think, things like intellectual humility, benefits of being open to changing your mind about things. I don't usually like a lot of nonfiction, to be honest with you, but I thought this was evidence-based, practical, well-written. So I would recommend that. Adam Grant's book, Think Again, Power of Knowing What You Don't Know.
Great. We'll definitely add that to our show notes. Dr. Chou, is there anything that you'd like to add to make sure our listeners know about the specialty of plastic surgery?
Yeah, I think we've covered a lot of ground, and you can probably guess that I'm someone more interested, at least now, in terms of going into reconstructive microsurgery, but you might have gotten different responses if you were to have a plastic surgeon who does more aesthetics, or a plastic surgeon who does craniofacial, or even hand. It's a wide field, and those are even just the areas you can do a fellowship in, but we also do burns and things like that. So I would just really want to emphasize to students that it's a broad field, and it's as broad as it is deep. So it's not just what you see on TV. We do a lot of awesome things. I think it's the best specialty out there, because you get to work with patients all ages, work with all different types of tissues, skin, bone, tissue, blood vessels. You get to work with all ages, head to toe. You get to do surgery and really help guide people after some of the worst days of their lives, whether it be cancer, trauma, and bring them back to feeling whole, and getting them back to a place where they feel maybe even more human again. So I think it's the best specialty. At health systems level, you can bring tremendous value to the whole system, patients, communities. That all being said, of course, not the right specialty for everyone, and I'm happy to talk to anyone who wants to talk offline a little bit more. But yeah, thanks again for having me. I had a great time, and I hope you edit out all the things that my bosses won't like hearing about. So again, had a great time. Thanks for having me.
Well, Dr. Chou, this has been great. I've learned a great amount of information about plastic surgery, and it's been a pleasure having you as a guest on the WMed Specialty Spotlight. For everyone listening, we'll wrap up the show with that. Well, I hope you enjoyed the conversation with Dr. Chou. For the resources and other tidbits that were mentioned in this episode, you can find them in the show notes on the WMed website, wmed.edu/specialty spotlight. If you like what you heard, please share this episode with your fellow medical students, especially if they're having some career anxiety. It is truly my hope these conversations with physicians who've been there and done that will help you move forward with your own career choices. For any questions, or if you'd like to reach out to me for any reason, which I encourage you to do, you can do so by email me at bren.shaw@wmed.edu. But until next time, take care.